So I'm Dr. Steve Priest. I'm the Research Centre Director in the Centre for Health Sciences Research at the University of Salford, which is based within the School of Health and Society. And I've worked at the university now for about 15 or 20 years. While I do a little bit of teaching, most of my work focuses on research in biomechanics and rehabilitation. And I'll be sort of talking a little bit about the research that I do, just to sort of bring examples into this quantitative design lecture as we go through today. So these are the expected learning outcomes. We want you to understand the principles and assumptions of quantitative study or quantitative research design. We want you to understand that there's actually different types of quantitative research designs, and we want you to be able to think about what sort of design will be appropriate for a given problem, but also to be able to recognize when you read research papers what sort of designs other researchers have used to answer specific research questions. We want you to understand the strengths and weaknesses of these different quantitative research designs and to be able to appraise the choice of research design in the context of the research question. Now, I know that a lot of people on this call are probably going to choose a qualitative research project. And it's my sort of goal, if you like, to try and sort of persuade some of you that, you know, it is really important that we think about quantitative research. And hopefully some of you might at the end of this lecture think, actually, I would now entertain doing a quantitative research project. But irrespective of that, when you do go back into practice, you know, I hope that you are reading research papers and using research to inform your clinical practice. And I think it's therefore really, really important that you do understand the basics of research design, because most of the papers that you will read will be quantitative, and be able to understand and interpret those and use that sort of interpretation for your own practice. So this is the content then today. So we'll talk a little bit about primary and secondary research, then about the principles of quantitative research. Then I'll talk about the different types of quantitative research questions. So we've got level 1, level 2, and level 3. And then talk about different experimental designs, so non-experimental designs, true experimental designs, and research validity and reliability. And then we'll talk about sort of in more detail about true experimental designs, quasi-experimental designs, and then we'll talk a little bit about epidemiological designs as well at the end of the lecture. Oh dear, 2 slides. So that slide, unfortunately, that hasn't come out quite right, has it? So this slide, it just talked a little bit about primary and secondary research. And what we're going to be talking about today is primary research. So by primary research, what we're referring to is new research. So we're talking about collection and analysis of data that did not previously exist. So you're going out, you're collecting some data, and you're doing some analysis. And that's different from secondary research. Secondary research is where you are looking at other people's research, you're sort of reviewing things, maybe putting things together, summarizing research which has been done before. So I'll just say a little bit about secondary research in this one slide before we go on and talk in detail about primary research. So why would you do secondary research? Well, sometimes, often actually, you'll use the secondary research to inform your primary research. So you want to understand what people have done before, and that will help you sort of guide your research question. We'd also use we'll also use secondary research to inform guidelines. So I'm sure you're all familiar with things like the NICE guidelines, and the way that they're created is you get a panel of people that will review in detail all the primary research that's been done in a particular area, and they'll sort of bring those findings together to formulate guidelines. You're probably all familiar with the Cochrane Library as well. So that's a sort of database of reviews. And again, what people are doing there is reviewing all the primary research in a particular area to come up with some sort of definite recommendations, guidelines, or some statement on the level of knowledge in a particular area. But as I said, what we're going to concentrate on today is not secondary research, but is primary research. And I thought before we go over the sort of different quantitative designs, it's important just to sort of reiterate the basic principles of quantitative methodology. Now, I think this has been covered in an earlier lecture, but it's always useful just to sort of go over it again. So quantitative and qualitative are very, very different. With the quantitative approach, what the researcher is aiming to do is establish a single reality and essentially create or discover the rules which determine that reality. And we're trying to do that ultimately so that we can make predictions about particular aspects of health or disease or some aspect of society or social policy. So, for example, we want to understand why certain people will suffer from certain diseases, whether there are certain sort of drug treatments that will work effectively for particular conditions. And we want to be able to do that in a very, very systematic way so that we have all these rules and predictions and that all the sort of different theories, if you like, fit together. There's no inconsistencies. So the way quantitative methodology works is that we suggest a theory, we have a theory, and then we use what's called deductive reasoning to generate specific hypotheses. So the word deductive probably sounds a little bit confusing. You might not know what that means, but essentially all it really refers to is this idea of going from a big idea, a big theory, to a very small single hypothesis that can be tested with experimental design. So if I give you an example, if we sort of think about osteoarthritis, we might have a theory that osteoarthritis is related to the breakdown of cartilage in a particular joint, and that breakdown is influenced by mechanical factors. So that's a sort of big idea, and we might have a very, very small hypothesis related to that. So we might look, for example, at certain ways in which people coordinate their knee muscles during walking or other functional movements. And then we might be able to relate that to an MRI scan of the cartilage. And actually people have done this research and they've shown that actually people that overactivate their knee muscles actually have more rapid degeneration of cartilage. So that's a very specific hypothesis, but it sort of feeds back into that general idea that osteoarthritis is related to cartilage breakdown, and it's related to the way in which we load the joint. So quantitative research essentially continues sequentially. People have these big theories, and then there are individual studies that are done to test specific hypotheses. Once the study's done, you sort of ask yourself the question, well, does the results of that hypothesis testing fit within the bigger theory? And if it does, then we accept the theory. If it doesn't, if it sort of contrasts with that theory, then we would then have to reformulate the theory and again do some more experimentation to try to test hypotheses related to the new theory. So key aspects of quantitative methodology is that facts are obtained through objective observation, and that the measurement has to be independently done by an observer. So what do we mean by that? Well, if two people do exactly the same experiment at completely different laboratories, different parts of the world, we would expect the results to be exactly the same. We would expect an objective measurement. It's not influenced by that particular individual, the person who's taking the measurement. We need to reduce all observations to a single number. So we're always doing some sort of statistical or numbers-based analysis in quantitative methodology, which means that all the things that we're dealing with, we have to quantify. So if I sort of go back to that previous example where we talked about osteoarthritis, we have to quantify this change in cartilage, and we'll do that with an MRI scan, and then we'll do some measurements of the thickness of the cartilage of change through the MRI scan. So we've got a definite number to quantify this idea of cartilage degeneration. Once we carried out our hypothesis, we've got our numbers, and we can perform some statistical analysis to test our particular hypothesis. Other things that you need to be aware of that we'll expand on more through the lecture is that we try to control conditions as much as possible in quantitative methodology, and we're often manipulating one variable whilst we measure another. So as I said before, we use hypothesis testing to refine our theories. We want to be sure that the results of our hypothesis test fit with our bigger theory. And we want to come with come up with this generalized theory that fits with other theories, have this consistent set of rules which allows us to understand all different aspects of the world in which we live. And what we're trying to do ultimately is to bring together these observations into meaningful patterns so that we can make predictions, and we keep doing quantitative research sequentially, continually refining our theories based on the outcome of our hypothesis tests, which are done in each of our experiments. So as I said before, the key with quantitative, and that sort of is the word, you've got to quantify things, you've got to measure things, you've got to reduce everything that you're studying to a particular number. And once you can do that, we use different types of statistics, either descriptive or inferential statistics, to try and make sense of these numbers. Now, what we're doing in quantitative research is typically studying in the sort of fields of health and society. We're studying a sample of people, and we're drawing that sample of people from a much, much larger population. And so the findings are normally presented with a number which quantifies our level of confidence. And a sort of very approximate way of thinking about that is just to think that that number quantifies, if you like, how confident we are that that finding in our study can be extrapolated or generalized to the wider population. So when you see that p-value p equals 0.5 or 0.1, we'll go over this in a little bit more detail in the statistics lecture, but essentially what we're saying there is we've got a certain level of confidence that the finding that we've got of this particular sample can be extrapolated and generalized to the broader population. So just some examples then of quantitative research. So for example, one study might be an epidemiological investigation of type 2 diabetes. So we could think about the different factors which might influence the onset of type 2 diabetes, and they could be related to people's diet, exercise habits, etc. And we would put numbers on those, and then we'd quantify whether people developed diabetes or not. We could study joint loading in knee osteoarthritis. I talked about that before, this idea of studying muscle patterns, of quantifying cartilage changes and relating the two. We could study footwear design, and this is something I've been involved in, where we systematically change certain aspects of a shoe, and then we understand how that impacts on the pressure within the shoe. And I've done that experiment because people with diabetes will often experience skin breakdown if they get high pressures under their foot. And so it's important to understand how we optimize the design of shoes. Or we could simply do a randomized control trial, and we would do that by comparing two different joint replacements, for example, or two different treatments for osteoarthritis of some form. So this was the study that we did on footwear design. What we wanted to do was to understand how to optimize the design of the footwear. And we wanted to do that in order to minimize pressure within the shoe so that we could minimize the possibility that people with diabetes would develop these foot ulcers. One of the key sort of ideas within quantitative is that we systematically vary one variable whilst keeping the other ones constant. So don't worry too much about the sort of the individual footwear parameters that we vary, but just understand that there were certain characteristics of the shoe, for example, the rocker angle or the position along the shoe where the shoe starts to curve up. And those characteristics were systematically varied by designing different shoes where we changed one thing at a time, and then asking people to walk in these different shoes. And by doing that, we could understand which type of footwear designs were associated with the lowest pressures within the shoe. So the word that people use in quantitative research for putting numbers onto things is what we call operationalization. So don't be put off by that term. It's just the way in which we quantify the phenomena that we are interested in. So I've said in the last few slides how we need to quantify every type of phenomena that we're studying. And there's a whole sort of field that's associated with this. Now, when we're talking about something in a laboratory, it's more straightforward. So I talked a little bit before about the example in osteoarthritis, where we could quantify cartilage change with an MRI, or we could quantify knee muscle activation using electromyography, which is like electrodes that we stick onto the muscles. It gets more complicated when we're trying to quantify more subjective phenomena. So if we're trying to understand the effect of a particular treatment on, say, asthma or on low back pain, we need to be able to quantify the severity of symptoms that are associated with those two conditions. And to do that, we would use something called an instrument or a questionnaire. And we're going to look a little bit about that now. We're going to go and look at some of those interactive materials. But before we do that, just sort of understand that when we do a randomized control trial, there's normally what we call a primary outcome measure, and that's the most important outcome measure. And that's, if I think about that example of low back pain, that might be the way that we think is most appropriate to quantify people's experience or people's subjective feelings of pain or disability that are associated with that condition. Okay, so let's carry on with the lecture now. Hopefully that gave you some indication then of how we choose outcome measures for the subjective phenomena. So how do we develop these questionnaire instruments? So this is the research process. I typically think about it as 7 steps. The first is to identify a philosophical foundation to frame your research question, determine the supporting knowledge and theory base, develop your specific research question, and then select a design strategy and some study boundaries. Consider ethical issues and obtain information. Analyze information, draw conclusions, and then share and use your research knowledge. So that sharing is when you write up your research for publication. So what we're essentially doing today is we're thinking about number 4, which is to select a design strategy and set some study boundaries. So it assumes that we've already looked at the previous work, which would be number 2. We've thought about whether we're going to use a quantitative or qualitative approach, which would be number 1. We've gone through the theory base, number 2, and that we've developed a very specific research question. What we're doing today is thinking about how we would answer those questions with a very specific quantitative design. So what you'll do, hopefully, if you do decide to do a quantitative project, or if you do a qualitative project, is that you'll carry out a review of the literature. So you'll try to sort of define some specific search terms, and then you will identify key papers that are related to the topic that you want to do your research on. And it's always a good idea to sort of produce a sort of mental map or a mind map of all the different ideas and all the different papers that have been written to date. And with quantitative research, you should be able to identify whether each paper is a level 1, a level 2, or a level 3 study. So I'll just explain those different levels of knowledge now. So the first one, level 1, is simply a research question that seeks to describe phenomena. So it's designed to elicit something about a single topic or population for which there's not that much known. So for example, what's the frequency of assistive devices? What's the prevalence of fear of falling amongst community dwelling adults? What are the characteristics of a certain type of gait pattern? We're not trying to understand any relationships here. We're just trying to sort of describe a particular phenomenon. So if we're just trying to describe, for example, the prevalence of a disease in a population, so what's the prevalence of coronavirus amongst younger people in schools, that's just a level 1 descriptive study. We're not trying to understand a relationship of any form. Level 2 questions, we are trying to study relationships. And we're typically doing this where we've already carried out a level 1 study to understand whether this is an important topic to look at. So some examples there from some of the research that I've been involved in. What's the relationship between exercise capacity and cardiovascular health? What's the strength what's the relationship between the strength of the hip adductors and the severity of knee osteoarthritis. Now, what's key here is that we're not actively trying to change anything as a researcher. We're just trying to understand a link or a correlation between two separate variables. Now, level 3 is different because what we're trying to do here is test knowledge about cause and effect. And to do that, we change one variable and then we monitor another variable. So we're trying to understand what's the effect of changing one thing on something else. So the easiest way, I think, to sort of exemplify this is to think about a randomized control trial. You have two groups of people. One group are in a control group, and that group, you don't change anything at all. In your intervention group, you give them a specific treatment. So you are intervening, you are changing one thing, you're giving them a treatment. So an example might be the coronavirus vaccine trial. You've got your control group, you've got your randomized, you've got your experimental group, and you're manipulating something in that one group. You're manipulating their, where you're giving them the vaccine and you're having some effect on their immune response. And then you're looking at what effect that has. You're looking at what effect that has on the prevalence of coronavirus, for example. So you're actually actively changing something. So some other examples, with strengthening of the hip adductors, improve clinical outcomes in patients with knee osteoarthritis. So we're actually doing something there, we're strengthening these muscles, seeing what the effect is. And to what extent do different footwear designs reduce pressure under the foot during walking in people with diabetes? So again, we're changing something. We're changing some aspect of the footwear design, and then we're monitoring what effect that has on the pressure within the shoe. So these level 3 designs typically require what we call a true experimental design, which I'll go over later on in the lecture. So we talked earlier about hypothesis testing and about how this is a central part of quantitative research design. So a hypothesis is a proposition to be tested, or a statement of a potential relationship between two variables. So we only have hypotheses for level 2 or level 3 questions. Clearly, if we're just trying to describe something, we can't have a hypothesis about a relationship, because level 1 studies only really refer to, level 1 studies only deal with explaining or describing something. They don't deal with relationships. And the hypothesis is the researcher's best hunch about a phenomena. So essentially what we're doing is we're taking that research question and we're saying, what would be the particular direction of this relationship? So if we're thinking about, for example, does strengthening muscles improve outcomes in knee osteoarthritis? We would try to be very explicit about the direction of the effect. So we'd say, when we strengthen muscles, there is a reduction in knee pain, for example. So we're saying we're improving strength, increasing strength, but we're then decreasing pain. So we're being very specific about the anticipated direction of that relationship. So what I'm going to do now is just talk a little bit about level 1 and level 2 designs. So these are these descriptive and these correlational studies. So level 1 is what we call a non-experimental design. Think about this when we're just describing a particular phenomenon. And the sort of designs that we'd use are surveys, needs assessments. There's no manipulation, there's no randomization, there's no control groups. Very, very simple studies. So for example, we might do something like, what's the prevalence of COVID-19 in school children in the UK? Or what's the frequency of falls in people over the age of 65? So you can see that all we're doing is we're taking a group of people and we're doing one single measurement on them at one particular point in time, and we're just descriptively reporting what we find. It's just a description of that particular phenomenon, of how much of something is, how often do people do this, how big is this? It's just a sort of description. There's no relationship in there. Level 2 designs, if you think back, are about trying to understand correlations or understand links between variables. So again, we've got no manipulation, no randomization, no control groups. We're not trying to change anything. We are just taking multiple measurements at a single point in time and looking for links between them. So let me give you some examples. So this is a study that we've done on people with knee osteoarthritis. And what you see in that left-hand graph there is a measure of how flexible people are in their hip. So we've got the people with knee osteoarthritis, and you can see that they've got lower flexibility. So they've got a higher hip flexion angle. That means that they're less flexible in comparison to the healthy people. So to do that, we've taken a group of people with arthritis, we've taken a group of healthy people, and we've measured their flexibility at one single point in time, and we've compared the two groups. So we're not trying to change anything, but we are trying to describe a difference between two groups. And we've got the same data there on the right-hand side, and that's to do with the way that how much people have this forward lean in walking. So you can see that the OA group lean forward 4 degrees, whereas the healthy group only lean forward about 1 degree in walking. So we're just comparing the value of a particular variable between two groups. Level 2 designs can sometimes be a group comparison. Do we just compare between like a pathological and a healthy group? Or do we want to sort of understand how two variables are related together? So again, if we're going to look at this relational design, what we would do is take lots of people, and then we would measure two variables for each person, and then we plot one variable on the bottom axis, one variable on the vertical axis, and we just see if there's a link between them. Now, we can use more complex statistics, but this is the essence of what we're trying to do here. So this is a graph of resting energy expenditure. This is how many calories that people would use in a day if they didn't move at all, so they're just laid still. And then on the vertical axis, we've got lean body mass. So this is how much non-fat mass people have. And there's actually a very, very strong link between your energy consumption and your lean body mass. And you can see that on the graph there. And so what that means is that people who are bigger in general have to eat more. And it's quite interesting that the government guidelines don't necessarily reflect that. They give guidelines which are very much, you should eat this many calories if you're a man and this many calories if you are a woman. But those guidelines to me are completely ill-informed because of this relationship here between the energy that you need and the size of your body. This is a sort of building on that data I showed you before from people with knee osteoarthritis, where we took a group of people with knee osteoarthritis, and they're the black dots, and a group of healthy people, and they're the unfilled dots. And what we've done is we've correlated the flexibility in their hips, which is on the bottom axis, with how much they lean forward, how much they're flexed when they're walking. And what you can see there is that there is a relationship, so that people who have less flexibility in their hips, so a higher hip flexion angle at the bottom, have more forward lean. So less flexibility in the hips means that you lean forward more when you're walking. So again, we've not tried to manipulate anything there, but we have measured two variables, and we can see that very clear link between those two variables from our data. What it's worth saying, actually, before I go on to the level 3 designs, is these level 2 designs often are done in preparation for a level 3 design. So what we've seen there is that there's a link between flexibility and people's walking position. And what we also showed was that that walking position was related to muscle overactivation. So that sort of sets up a question: how do we change this clinically? Because if we've got increased forward lean and we've got muscle overactivation and we know that overstresses the knee, we need to change that. And so what this graph shows us is that one of the ways that we need to change that is by addressing this lack of flexibility in their hip muscles. So that sets up a level 3 question where we are actually going to change one thing and see what effect that has on the other thing like pain or walking position, etc. So we've talked about level 1 and level 2 designs. The level 1 designs are just these very simple descriptive studies. The level 2 designs are designs in which we are looking for relationships between two variables. But neither of those designs involve any sort of manipulation of variables, and we don't have any randomizations or control group. Now, level 3 questions as I said before, they involve us actually manipulating something. And there's three types of these level 3 designs. One's true experimental, quasi-experimental, and pre-experimental designs. And I'm going to talk through each of those in turn. But before I do that, it's important to understand exactly what we mean by manipulation, randomization, and the use of a control group. So these are essentially the key characteristics of what people refer to as a true experimental design: manipulation, randomization, and a control group. So your control group is typically a group which doesn't have anything done to them. And you need that because you want to be 100% sure that when you do this intervention or this change in your experimental group, that when you see that that has an effect, you want to be sure that there's no effect on the control group. So you can compare the effect of doing nothing in a control group to doing something in this experimental group. You'll often see the words independent and dependent variables when people are talking about level 3 design, so these sort of true or experimental designs. So the independent variables are the variable that the researcher manipulates, and the dependent variable is the variable that you're interested in. So if we think about a coronavirus vaccine study, the independent variable would be the vaccine, the presence, whether you give the vaccine to someone or not. The dependent variable would be a coronavirus test. So do you develop the coronavirus? So the hypothesis is that if you give the coronavirus vaccine to this group, that you would have a lower prevalence of coronavirus. So another example, if I go back to that idea of footwear, we can manipulate the footwear design, and we could measure something mechanical about the way that footwear has affected walking. So that could be the pressure under the foot or the moment or forces at the knee joint. So we're manipulating one thing, which is the footwear characteristic, and we're measuring another thing, which is something to do with the mechanics of the way in which people walk. And we would do that in one group, but not in the control group. Now, when we're designing an experiment, we need to think about what we called confounding factors, and they're factors that can erroneously influence the outcome of our study. So one of the earlier examples I gave was around studying the effect that footwear has on in-shoe foot pressures. So to do that study, we took a group of people with diabetes and we instructed them all to walk in these different types of footwear, and then we compared the pressures in the shoe between these different types of footwear. And we did that so that we could understand precisely what effect changing certain aspects of the footwear design have on these pressures. Now, but what we've got to be careful of is are there any other factors which could influence foot pressure? So one factor is walking speed. So if you think about a scenario in which you've got two shoes and you're trying to compare them, and in the first shoe, the people, for whatever reason, for some random reason, end up walking faster than in the second shoe. And that when we walk faster, pressure actually goes up. We could end up concluding that the second shoe, the design of the second shoe leads to higher pressures. But actually that wasn't the case. The reason we got those higher pressures was because we didn't control for this confounding variable of walking speed. And it's the same in a randomized control trial. So if we go back to the example of the coronavirus vaccine, we know that the coronavirus affects old people much more readily than younger people. So if we had a lot more younger people in our intervention group and a lot more older people in our control group, we could erroneously conclude that the vaccine was effective when actually it wasn't, because the only reason that you saw a lower prevalence of coronavirus in the younger group, in the intervention group, was that there was more younger people. So you've always got to be thinking about what are all the factors that could influence my outcome and that I need to control for. And the way that we do that with a randomized trial is that we randomize people into the control and the intervention group. So randomization. So we do this to try and control for any sort of confounding factors. So I think about, I think the coronavirus is just such a good example because the disease affects people in a completely different way depending on your age and whether you've got any pre-existing conditions. So what you're trying to do is get the same level of or the same distribution of demographic characteristics in each arm of the study. And when people talk about an arm, they're just talking about a group within the study. So we want, if we're doing a coronavirus vaccines trial, we need equal numbers of males and females in each group. We need approximately equal numbers of people in these different age categories. And that's going to stop these confounding factors from influencing our conclusions. So what we're trying to do is avoid any bias. Bias is the key word here. We don't want our comparison between the groups to be influenced by bias. So we're essentially using randomization to reduce anything which erroneously influences conclusions about groups or distorts group comparison. Now, in some scenarios, it's not possible to include a control group. And in that scenario, what we do is we come up with a slightly different design. So it's not a true experimental design. It's what we call a quasi-experimental design. And with a quasi-experimental design, we're still doing manipulation, but we don't have the control group we don't have the randomization to define the control group. So we still have a control group of some form, but we don't use randomization. And there's just certain scenarios where that's just not possible. So, for example, if we have a certain group of people in hospital who are all going to receive a certain drug, and we can't necessarily, it will be unethical to deny them a particular treatment, and we want to compare it to another hospital where they're using a different drug. And again, that's part of their guidelines. It wouldn't be ethical to deny treatment. We could do a comparison across those two hospitals. And we'd have to try as far as we can to avoid any of these confounding factors having an impact on our findings. So one way is to use matched pairs, so what we call research twins. So we tried to find a person in the first hospital who's the same age, weight, sort of demographic, socio-demographic status as the person in the second hospital. And we'd define all these what we call research twins. And then we'd then end up with two groups that were very, very similar in terms of demographics, and that would reduce the potential for these confounding factors to influence our findings. Another way of doing it is to expose all subjects to all conditions. So we use what we call a crossover trial. So we might not want to deny someone treatment, but we could maybe delay it and get them to try treatment A first before they've started treatment B, and then another group they start treatment B first before treatment A. And then the final way to do it is to use what we call statistical control of confounding factors. So we use that using a technique such as ANCOVA. So for example, let's say we do know that the coronavirus vaccine disproportionately affects older people. We could feed the age of people into our statistical analysis. And then the statistical analysis will tell us whether the difference that we've seen between the groups still exists once we've controlled for age. So sort of complex stats can help you overcome some of these problems where you're not able to randomize people into two separate groups. Whether we do a randomized trial or not, it's really, really important that we are objective about the way we collect our outcomes. And that means that the person who collects the outcomes doesn't have any impact on the outcome itself. And to do one of the ways in which we do, obviously we want to develop very robust measurement procedures, but another way that we sort of try to ensure this objectivity is using what we call blinding. And there's three types of blinding. The first single blinding is where the experimenters, that's the person collecting the outcomes, doesn't have any idea of the group allocation. So if we go back again to the example of the coronavirus trial, you might have all these people who are allocated to be either in the control or the intervention group. They will be given medication, and then they'll come back regularly for a coronavirus test in the hospital. And the coronavirus test involves someone, sticking like a sort of swab up their nose. And so there is the potential, if that test isn't done properly, for the person who collects the outcomes to, subconsciously influence the outcome. And so those people who collected those outcomes, who did those coronavirus tests, would have been completely blinded to the allocation of group, whether people were in the control or the intervention group. The second is what we call double blind. So this is where not only the experimenter, but also the person that receives the treatment is unaware of group allocation. And again, that would have been the case for the coronavirus test. But when we're talking about something which is more complex, like a physiotherapy intervention, that's often more difficult. People, because of the nature of the way we're delivering the intervention, we can't necessarily ensure it's double blinding, because people will be aware whether they're getting treatment A or treatment B, because of the way it's delivered. It's not just a tablet or an injection. And the final is called triple blinding. So that's when the experimenter, the subject, and the clinician who's delivering the treatment all are unaware of group allocation. And you can sort of see that if you can achieve that triple blinding, which you would get in any sort of drug trial, any simple intervention trial, that you are minimizing the potential effect of all these confounding factors and any sort of bias that could be introduced by the way people collect the outcome measures. Now, the other thing that people will talk about in respect to quantitative designs is research validity. And this again is related to sort of the potential for bias to impact on the findings. If something's valid, it means that we can be more confident that actually it's a true representation of what's actually happening. It's not a finding which is a consequence of us not doing the experiment properly. So we've got two types of internal validity. And the first is that the reported outcomes are the consequence of the relationship between the independent and the dependent variables and are not due to a confounding factors. So one of the examples I gave before was this idea that you could do a coronavirus trial, not randomize people properly, have lots of younger people in one group and lots of older people in another group, and then you'd get a difference between the groups, which wasn't due to the vaccine, but was actually due to the fact that you've got this confounder of age influencing your findings. So if that was the case, you would be said, the experiment then will be said to have very low internal validity. The second is that you're confident that the manipulation of the independent variable caused the outcome to change. So if I sort of use that example of the footwear design, where we independently manipulate one aspect of the shoe, and we see a change in in-shoe foot pressures, we need to be really confident that that change has occurred because we've changed this one aspect of footwear, and not because, for example, the person just walked faster or some other confounding factors influenced it. So again, we need to think about that internal validity. External research validity is our capacity to generalize the findings to a larger sample. So as I said earlier in the lecture, when we do quantitative research, what we're doing is we are looking at a relatively small sample, and we're saying, can we take the sort of findings and the outcomes from this small sample and generalize it to the much, much larger population? So there was some issues around this in one of the coronavirus trials, I think with the AZ trial. They didn't feel, some of the regulatory agencies, that there'd been sufficient older people in this sample. And so they were just a little bit worried that they couldn't necessarily extrapolate their findings from the trial right through the general population because they didn't have enough people represented in older age groups. So that's just one example that Where when you're doing a study, you need to be thinking about you're taking a sample of people in your trial, and ultimately you're trying to say whether something that maybe whether a drug works or a certain type of treatment has this physiological effect. You simply can't study everyone. You can only study a sample, but you need to make sure that your sample is sufficiently representative that you can then draw that wider conclusion across the population. And the final types of research validity are statistical and construct. So the statistics is key, and that's not something I want to talk too much about in this lecture, but essentially, if your statistics haven't been done correctly, that questions or calls into question the whole validity of your study. So you need to be sure that you've done the maths correctly, and that when you say this hypothesis is proven or not proven, that you can be confident that you're doing that based on correct statistics. Construct validity is all related to operationalization. So like we talked about with the questionnaires, it's how we put numbers on things in the study. And we need to be sure that we've put the numbers on things in the right way. So if we did a study of a specific intervention in low back pain, and we chosen a specific questionnaire which maybe didn't reflect the way a lot of people experience back pain. So say a lot of people experience back pain by stiffness in the morning or the ability to bend over and tie the shoelace. If we didn't have those questions in our questionnaire, but we showed that our treatment was effective, people might question whether it had correct construct validity because we weren't really measuring, operationalizing this concept of back pain properly. Okay. And then the final thing to think about is reliability of research design. So if the same results can be obtained under the same circumstances, then we could be confident that the experiment is reliable. So as I said right at the start of the lecture, we want to be able to replicate quantitative findings across different laboratories or different settings in the world. We don't want this to be specific to our particular lab or our particular healthcare setting. So we really do need to be confident that when we've done things, we've done them in a very systematic way, a very unbiased way. And if we do them on multiple separate occasions with our very rigorously designed experimental procedures, that someone else will be able to come in and repeat the experiment. And one of the ways that we would sort of do that is that typically when we're measuring an outcome, we might do the same measurement over 4 or 5 days and then just be confident that we can get exactly the same answer day after day after day. And if we can't, we have to go back and think about our measurement procedures. So just returning then to these levels of knowledge, remember level 1 is a descriptive design, it's just a survey or a needs assessment. We don't study any relationship. Level 2 is a passive observational study. So we measure something, but we don't try and change anything. We don't try and manipulate any variables. Level 3 is different. Level 3, we try to change one thing, and then we try to understand what effect changing that one phenomena has on something else. And for this, we require a true experimental design. So I'm going to talk about 2 specific true experimental designs. The first is a randomized control trial, and the second is what we call a crossover trial. So we've got these characteristics of manipulation, randomization, and a control group. These are absolutely essential for a true experimental design. So I've spoken quite a lot through the lecture about a randomized control trial. And obviously these are used to test efficacy or effectiveness of treatments, and it's considered to be the gold standard, the most rigorous way to test cause and effect between treatment and outcome. And it's the best way to avoid all the sort of biases and the potential impact of confounding factors that I've spoken about in the last few slides. And just remember that we measure the dependent variable, but that we manipulate the independent variable. So if you think about the best way to remember that is you think about the dependent variable being the one that depends on what you do, and the independent one is the one that you change. Okay, so this is essentially how a randomized trial works. You divide people into a minimum of 2 groups. One of those is a control group, and they get nothing at all. So you take an observation right at the start. You give this control group nothing or some sort of placebo treatment, and then you take an observation at the end, and you do the same thing with the treatment group. They get an observation at the start, which might be pain or coronavirus symptoms, disease, etc. They get their treatment, and then you get an observation at the end. And occasionally you'll see what we call a post-test design, where you don't do the baseline measurement, you just give the treatment and you do the observation at the end. But if you're going to use that design, you've got to be 100% sure that there's not going to be any differences at all before you start giving the treatment. The other type of design which is sometimes used, and which it can be a true experimental design, is what we call a crossover design. So with a crossover design, everyone gets every treatment. So you still divide into 2 groups, and you still do this observation before you do any treatment. You then do the treatment in group 1, and the group 2 receive nothing or a placebo, so they're the control group. And then you do the observation. Now, if you stopped there, that will be a standard randomized control trial. But what some people will do is then switch so that the people that receive the treatment then get a placebo, and the people who receive the placebo then get the treatment. And then you do another observation at the end. And sometimes that can be more sort of interesting and maybe give you a bit more insight into how the treatment affects all the different people in your particular sample. Now, you do sometimes see this crossover design done without randomization. So when it's just not possible to randomize. And if that's the case, it's not called a true experimental design then, because you've not got the randomization. But because you've given everyone every treatment and you've looked at these outcome measures at different time points, it does give you a lot of power to try and understand and investigate your research question when you are limited by that capacity to randomize into 2 different groups. So we think about level 3 designs. The first one that we've talked about is the true experimental design. And now what we're going to talk about is the quasi-experimental design. And that's when we don't have randomization. So we're still manipulating, we're still doing some sort of treatment, or still changing one variable, and we still have a control measurement. But what we're not able to do is randomize into these 2 groups. One is the treatment and one is the placebo or the control group. So quasi means resembling. So quasi-experimental research, it's not true experimental research. It resembles true experimental research, but it's not true. And the participants are not randomly assigned into treatment and intervention groups. And as I've said, there are sometimes issues with this random assignment. So there could be ethical issues that could be studied in a setting where you are going to give this one treatment to this particular group of people, and therefore it's just impossible to deny or sort of withhold that treatment. And in that case, you can do these quasi-experimental designs. So we can do them with or without a control group. And what we use is what we call this interrupted time series design. So by an interrupted time series, I mean that we're making a set of measurements over time, and then we're interrupting that measurement with a treatment. So we might take 2 or 3 measurements, maybe 1 a month, and then we would give a treatment. And then we would again take 2 or 3 measurements after the treatment. So if we're thinking about a group of people who have back pain, we want to understand the sort of stability of that pain over 2 or 3 months. We know they're going to get this treatment anyway at a certain point in time, and we can't necessarily withhold the treatment from anyone. So every single person is going to get the treatment. So we can't define a control and an intervention group. But what we can do is take these baseline measurements on a few different time points and use this interrupted time series design to see how the treatment affects them further down the line. Now we can do that with or without the control group. So the second box there shows with a control group who don't get treatment. But as I said, with the quasi-experimental design, we're not randomly dividing people into, we're not randomly allocating people into a control and an intervention group. So whilst there is two groups there, we wouldn't be able to sort of randomly select people to go into group 1 or group 2. They would get put in because they're going to experience or receive the treatment anyway. So level 3 designs, then the last one is what we call a pre-experimental design. And if it's a pre-experimental design, whilst we do have manipulations who are doing something, we're giving them a treatment or changing something, we don't have randomization and we don't have a control group. And these sort of designs are called either one-shot case studies or pre-test or a pre-test post-test design or pre-post design, people call it. So a one-shot experimental case study is where you simply give a treatment and take an observation at the end. But there's no way of knowing what happened before the treatment. So those sort of studies have got low internal validity. The second design is what we called a pre-test post-test design. So you take an observation, you give the treatment, and you take an observation again. So it's like your randomized control trial, but without any control group. You're just giving everyone the treatment. They can give you some quite good insight, but because you've not got this control group, you just don't know to what degree that any change that's occurred from the treatment would have occurred anyway, or might have occurred due to some confounding factor. Okay, so the last couple of slides then are about epidemiological designs. Does anyone have any specific questions about the sort of different levels of design, level 1, 2, or 3, or about randomized control trials, or about anything you've read on those extra learning materials that I've put up on the internet? No questions? Okay, so the last couple of slides then is about epidemiological design. So there's two key types of epidemiology. So epidemiology is the study of factors that contribute to disease. And if we're going to study the factors that contribute or lead to the onset of disease, we need to identify and sort of divide people into two groups. They're the ones that get the disease and the ones that don't get the disease, and then try to understand the factors that might have led to people developing the disease in one group but not in the other group. So there's two types of designs. The first is what we call a case control study, and this is where we do the observation at a single point in time, and we ask people to recall. We've got a question there from Nicole. So let me just stop talking about the epidemiology and answer that question. Can an RCT be used to compare screening cost effectiveness? It could be. It's quite a complex design if you wanted to understand cost effectiveness. So you have to not just look at a particular clinical outcome, but you have to then quantify the cost of a particular treatment. So when you're looking at cost effectiveness, you're not just looking about whether there's a difference between two groups. What you're looking at by cost effectiveness is what it costs to deliver the treatment and how that compares to how effective or the improvement in a particular outcome. So what people will normally do is they quantify cost effectiveness as a quality adjusted life year. So there's various questionnaires that you can use that will give you a measurement of how people's quality of life have improved as a result of the particular treatment. And you can look at that and how that quality of life differs between the control and the intervention group. So you get a measure, if you like, of the difference or the change in the quality of life that's resulted from the particular treatment. And then once you've got that measurement, you can translate that. There's various algorithms that translate that into a quality adjusted life year. And then You then relate that back to the cost of the treatment, and then that gives you a measure of cost effectiveness. So yeah, it's normally tagged on to an RCT. You'd normally have the RCT to, if you like, understand whether you've got a clinical effect, and then you would do the cost effectiveness study alongside that with a health economist. So coming back to the epidemiological designs then, so we're talking about a case control study. And with a case control study, we're asking people to recall information about potential risk factors. So let's say we were interested in understanding the factors that might predispose people to developing lung cancer. If we're going to do a case control design, we would go out and we would identify a group of people, say 100 people who are suffering with lung cancer and 100 people who are not suffering with lung cancer. And then what we would do is we would ask them to recall all the information that we can about the factors that might have led to lung cancer. So we might ask the people in both groups to sort of recall how much various lifestyle factors, but how many cigarettes or whether they've been involved in smoking and the degree to which they'd smoked over the previous 10 years. And then we'd compare those histories and draw conclusions. Now, you can see that's problematic because you're relying all the time on people's ability to recall, and you can't go back and take physiological measurements. All you can really do is ask people to sort of fill out questions. So it's quite limited what you can do with a case control design. The other design is what we call a cohort study. And with a cohort study, we start with a big group of people who none of which have the disease. So if you wanted to study lung cancer, you'd start with a big group of very healthy people. And then you would assume that a group or a subset of these people will be exposed to the factors that predispose to disease. So for example, there might be a group of those people who begin smoking, who already smoked but didn't have lung cancer at the time. So some of those people will be exposed in that group and some of them will be non-exposed, and you follow them through time and you continue to take these measurements of the factors that relate to the risk to the disease. So if that's lung cancer, it could be cigarettes. If it's type 2 diabetes, it could be various lifestyle factors, activity patterns, diet, etc. And you monitor these continually over time. And at the end of the study, you'll end up with a group of people who have the disease, a group of people that don't have the disease. And you can then study and relate those groups to the different exposures. So you sort of have this continuous set of measurements through your study that allow you to accurately understand which exposures led to the disease and whether a lack of exposure to a particular factor means that you don't get the disease. So does that make sense to everyone, the difference between those two epidemiology designs? Okay, great. So the last slide then is just about the hierarchy of evidence. And what you'll often see when you're reading things like guidelines is there's strong evidence for this, weak evidence for this, and then people will sort of take a view on all the evidence together and then make a clinical recommendation about whether we should use a particular treatment for a particular condition. So that hierarchy of evidence starts with things like expert opinion. So they're not rigorously carried out studies, they're just people's opinions, and case reports. There may be individual people who've received a particular treatment, or one or two people, and it's been written up as a case report. That's considered to be very weak evidence. A cohort study, so that's an epidemiological study. And remember, with an epidemiological study, you're not actually testing the effect of a treatment. What you're doing is looking at factors that could predispose people to develop a disease. So when we're trying to decide on whether we should deliver a particular treatment, that wouldn't be considered to be strong evidence. Strongest trial is the randomized controlled trial, but the strongest evidence is systematic review. So a systematic review draws together evidence from multiple randomized controlled trials. So it's considered to be the highest level of evidence. And ideally, let me just 1 second before I answer that question, Michelle. And ideally, if you're going to inform evidence-based practice, you would do that from the basis of a systematic review where you've critically appraised the results of multiple trials. So Rochelle's asked, if an RCT was chosen, would you recommend including epidemiological designs? No, if you're going to do a randomized control trial, then you would stick with that design. You wouldn't use an epidemiological design unless you're specifically trying to study the factors that predispose people to developing a specific illness. The randomized control trial is different because you're actually intervening, you're trying to change something, give a treatment and see what effect that has. Whereas with epidemiology, if you like, we're just allowing nature to take its course, or factors to take their course as they would anyway, and then was trying to understand which factors actually cause the disease to become prevalent, or the onset of the disease.